put yourself in the shoes of an emergency room doctor for a second.
Okay.
You're facing one of the most terrifying high-stakes catch-22s in modern medicine. Like, imagine your patient comes in, and they've just survived a spontaneous intracerebral hemorrhage.
Right, a massive brain bleed.
Exactly. It's an absolute crisis. I mean, the skull is a closed box, pressure builds up rapidly, and, brain tissue is just so incredibly sensitive to that expanding pool of blood.
It's devastating.
Yeah. But through intensive care, they make it through. The bleeding finally stops. You think, okay, we're in the clear.
But you're not?
No, because here is the twist. That same patient has a severe cardiovascular condition, a condition that absolutely requires them to be on blood thinners to prevent a fatal clot from forming and traveling up to their brain.
Right. I mean, it is the absolute definition of a clinical nightmare. We're looking at a scenario where the precise treatment for one life-threatening condition.
That clot.
Exactly, the clot. The treatment for that is the exact trigger for another life-threatening condition, the massive brain bleed.
It's like trying to fix a burst pipe in your house, but you have to keep the main water line pumping so the heater doesn't explode.
That is a perfect way to describe it.
You desperately need the water flowing, but you are terrified of blowing out that fresh patch you just placed on the pipe.
Yeah.
So, welcome to this deep dive. For you listening right now, whether you're prepping for clinical rounds or you're just, insanely curious about how doctors solve impossible problems, our mission today is to explore exactly how experts navigate this medical high-wire act.
It's a critical topic.
It really is. And we're pulling directly from a massive stack of sources today. We've got the latest guidelines from the American College of Cardiology, the American Heart Association, and a whole series of groundbreaking clinical trials.
And, it is so important to understand the fundamental mechanics of why this specific balancing act matters.
Right.
The ultimate goal here isn't just treating a single symptom in isolation. It's constantly weighing competing biological risks. Like if you picture a giant glowing set of scales.
Yes, I'm picturing it.
We have a thromboembolic event, a massive clot on one side, and an ICH recurrence, a catastrophic rebleed on the other. Every single biological factor and medical intervention tips that scale.
Okay, let's unpack this. We have to start with the most common scenario, right?
Mm-hmm.
Antiplatelets.
Yeah, the everyday stuff.
Things like aspirin or your standard over-the-counter NSAIDs. Now, to use our analogy, if a blood vessel ruptures, platelets are like the emergency sandbags.
Right, the body's first responder.
Exactly. The body quickly throws them into the breach to temporarily plug the hole. And aspirin's entire job is to stop those sandbags from clumping together.
That's what it does.
So if a patient just had a brain bleed, shouldn't aspirin be the absolute last thing we want to give them? I mean, it feels like throwing gasoline on a fire.
It feels completely counterintuitive, which is exactly why we have to look closely at the data.
Okay.
What's fascinating here is a pivotal study called the RESTART trial.
The RESTART trial.
Yeah. So they looked at 537 patients who suffered a brain bleed while they were already taking anti-clotting therapy. And the researchers randomized them into two groups. One group stayed completely off the drugs, and the other group was told to resume their antiplatelets.
Wait, really? Just resume them?
Yes, but the key here is the timing. They didn't start them immediately. They waited a median of 76 days post-hemorrhage.
76 days. So that's about 2.5 months.
Correct.
From a biological standpoint, what is actually happening in the brain during those 2.5 months that makes a doctor think, okay, the pipe is secure enough to take away the sandbags?
Well, over those weeks, the brain is actively cleaning up the site. The pooled blood, the hematoma, it's slowly resorbed by immune cells.
Okay.
And a specialized scar tissue forms. It's a process called gliosis. So the fragile, ruptured vessel walls actually have time to heal and stabilize.
Oh, I see.
Yeah, and once that structural integrity is reestablished, the immediate threat shifts back to the patient's underlying cardiovascular disease.
So what happened when they flipped the coin and restarted the aspirin after that 76-day healing window?
The outcome was pretty shocking to a lot of people. Resuming antiplatelet therapy did not increase the risk of recurrent hemorrhage.
Really?
In fact, the rate of recurrent bleeding was slightly, though non-significantly lower in the group that resumed therapy.
Wait.
Yeah. It was 4% in the resumption group compared to 9% in the avoidance group.
Hold on a second. You are saying the people taking the blood-thinning aspirin had a 4% rebleed rate, But the people completely avoiding the blood thinners had a 9% rebleed rate.
That's what the data showed.
How is that even physiologically possible?
Well, what's fascinating here is that the underlying vascular disease that's causing the clots in the first place, that might also be driving generalized vascular inflammation and stress.
Oh, like systemic stress across the whole body.
Exactly. By managing the cardiovascular disease with antiplatelets, you might actually be reducing the overall systemic strain on all the blood vessels, including the ones in the brain.
Wow.
And the long-term follow-up really cements this. They track these patients for up to 5 years.
That's a solid window.
Yeah, and the rate of recurrent brain bleeds remained much lower than the rate of major vascular events. We're talking a 9% risk for recurrent hemorrhage versus a massive 30% risk for major occlusive and thromboembolic events.
To put that in perspective for you listening, over 5 years, this patient has a 30% chance of a clot causing a massive heart attack or stroke, but only a 9% chance of another brain bleed.
Right.
So the math leans heavily toward preventing the clot once you are safely past that 76-day healing window.
Exactly. But, medicine never stops pushing boundaries. Once they knew 76 days was relatively safe, the next logical question was...
How early can we push it?
Exactly. Which brings us to the eSTART trial.
Okay.
This was conducted in China. They looked specifically at 269 patients with atherosclerotic risk factors who suffered a brain bleed and actually underwent surgery to evacuate the hematoma.
Okay, so these are post-surgical patients? A neurosurgeon literally opened the skull and scooped out the pooled blood.
Yes. Incredibly high stakes. And they tested starting aspirin aggressively early.
How early?
On post-operative day 3. And they compared that to a delayed start on day 30.
Wait, I have to push back here. Day 3 after actual brain surgery?
I know, it sounds...
I mean, you just went into a highly vascular organ, scooped out a hematoma, and on day 3, you are deliberately giving them a drug that stops platelets from clumping. How did an ethics board even approve that? It sounds like malpractice waiting to happen.
It absolutely sounds alarming at first, but you have to look at the mechanics of the surgery itself.
Okay, explain that.
By physically removing the hematoma, the surgeon immediately relieves that devastating intracranial pressure we talked about.
Right.
And they also manually cauterize or secure the bleeding vessels while they're in there.
Oh, I see.
So the mechanical stress on the surrounding tissue is vastly reduced compared to a patient who just has to, wait for their body to absorb the blood naturally over months.
So the surgical intervention artificially accelerates the stabilization of the pipe.
Exactly.
Okay, so what were the actual results of this day 3 gamble?
The early group, the day 3 group, had significantly fewer new ischemic or cardiac events.
Makes sense.
It was 20% in the early group versus 31% in the late group.
And what about the brain bleeding?
As for recurrent bleeding, there was practically none.
Really?
Only 1 patient had a recurrent brain bleed in the early aspirin group compared to 4 in the late group.
That is staggering. But knowing clinical trials, there's always a catch. I'm assuming we can't just apply this day 3 rule to every single patient who has a brain bleed.
You are absolutely right. There is a massive caveat, and it all comes down to brain anatomy.
Okay.
In the eSTART trial, over 60% of these patients had what we call deep hemispheric hemorrhages.
Meaning the blood vessels that ruptured were buried deep inside the core of the brain, rather than like near the outer surface?
Precisely.
Yeah.
Deep bleeds usually occur in tiny perforating arteries that are chronically damaged by high blood pressure.
Right.
If you control the patient's blood pressure, you largely control the risk of those specific vessels bleeding again. But bleeds near the surface of the brain, called lobar hemorrhages, are an entirely different biological beast. Because this trial was heavily skewed toward deep bleeds, we absolutely cannot blindly apply this day 3 rule to lobar hemorrhages.
Location dictates the risk. That makes perfect sense. So if platelets are just the temporary sandbags in our analogy, we need to talk about the concrete.
The heavy hitters.
Right. If a patient has a condition like non-valvular atrial fibrillation, where the heart quivers instead of pumping smoothly, blood pools in the heart, creating massive, highly stable clots.
Yes.
To stop these, antiplatelets aren't enough. We have to use full anticoagulants.
And this is where the tension truly ratchets up. Anticoagulants don't just stop the sandbags, they stop the concrete from ever setting.
Wow.
The coagulation cascade is a really complex chain of proteins in the blood. If you shut that down, your bleeding risk just skyrockets.
So what does this all mean for our matrix? If the stakes are exponentially higher with full anticoagulants, how do doctors even begin to calculate when it's safe to turn them back on after a brain bleed?
Well, for non-valvular AFib, the AHA and ASA guidelines suggest delaying the restart of oral anticoagulants for 4 to 8 weeks after the onset of the hemorrhage.
4 to 8 weeks. Why that specific window? Like, why not 2 weeks or 12 weeks?
Because it follows this U-shaped curve of risk.
A U shape.
Yeah. Restarting before 4 weeks carries significant bleeding risk because the brain tissue is still highly friable.
Friable, meaning fragile.
Yeah, it easily tears and bleeds. But if you wait too long, the stroke risk from the AFib climbs too high on the other side of the U.
Thank you.
Guidelines suggest the optimal net benefit actually occurs when you start them 7 to 8 weeks after the bleed.
Okay.
In fact, there was a fascinating observational study of 177 patients with an intracranial hemorrhage who needed anticoagulation. They mapped out the risks, and the combined risk of recurrent hemorrhage and ischemic stroke reached its absolute lowest point, its nadir, when the drug was resumed exactly after 10 weeks.
The nadir at 10 weeks.
Yep.
But obviously, a clinician can't just stare at a wall calendar and guess for every individual patient. Right?
No, absolutely not.
How do they actually tailor this 4 to 8 week window to the actual person sitting in front of them?
They rely on 2 highly specialized risk scoring systems to quantify the danger on both sides of that glowing scale we talked about earlier.
Okay, what are they?
To assess the risk of a clot forming in the heart, they use the CHADS-VASc score.
CHADS-VASc. Break that down for us.
So it's an acronym. It looks at age, sex, heart failure history, hypertension, stroke history, and vascular disease.
Gotcha.
And it assigns points to each factor. A high CHADS-VASc score gives the doctor a firm mathematical probability that this patient is going to suffer a devastating clot if they are kept off blood thinners.
Okay, so CHADS-VASc calculates the clot risk. What about the other side of the scale? The risk of the brain bleeding again.
For that, they use the has-bled score.
Has bled.
Right. This estimates the risk of major hemorrhage, and it's scored from 1 to 9. It factors in abnormal kidney or liver function, previous stroke, prior bleeding history, and age. By putting the CHADS-VASc score next to the has-bled score, doctors generate a highly individualized matrix.
You're literally pitting the math of a clot against the math of a bleed.
Exactly.
So let's say the math tells the doctor it is time to restart. The 48 weeks have passed, the CHADS-VASc score is screaming that a stroke is imminent, and the has-bled score is, low enough to risk it. What specific drug are they turning to? I mean, for decades, it was always warfarin, right?
It was, yeah. But there has been a massive paradigm shift toward a newer class of drugs called DOACs.
DOACs.
Yes, direct oral anticoagulants. For most patients with AFib who develop a bleed, guidelines now strongly suggest a DOAC over warfarin.
What is the mechanical difference? Why are DOACs outperforming warfarin?
It really comes down to precision. Warfarin is a blunt instrument.
How so?
It acts as a vitamin K antagonist, meaning it just indiscriminately blocks the production of multiple different clotting factors in the liver.
Oh, wow.
Yeah, it creates a very brittle, unstable system that is highly sensitive to the patient's diet and metabolism.
So it's messy.
Very. DOACs, on the other hand, act like sniper rifles.
Oh, I like that analogy.
Yeah, they target one single specific protein in the coagulation cascade like factor 10A.
So by surgically disabling just one piece of the cascade instead of, carpet bombing the whole system, the body retains a slightly better ability to manage minor bleeds.
Exactly. And the clinical data reflects this biological precision perfectly. In one major study, the incidence rate of recurrent brain bleeds was 2.5 per 100 patient years with warfarin,
Okay.
but only 1.3 per 100 patient years with a DOAC.
Let's translate that for you listening. Basically, if a doctor treats 100 high-risk patients for a full year, they would expect to see about 2 or 3 brain bleeds with warfarin, but only 1 with a DOAC.
Yes.
You are essentially halving the baseline risk of the drug causing another bleed.
Yeah.
That sounds like a massive victory for DOACs.
It is, but if we connect this to the bigger picture, we do have to temper that enthusiasm just a bit. DOACs are a massive step forward, but the data isn't completely bulletproof yet. We have early phase trials like Apache AF and SUSTART,
Okay.
but they didn't conclusively prove the absolute safety of resuming anticoagulation with these drugs. We are still eagerly awaiting the results of larger, definitive phase 3 trials.
Like which ones?
Specifically, Aspire and Enrich AF. Those will give us the final word.
So the scientific jury is still technically out on this.
Yes. And to highlight why we need that massive trial data, look at a subsequent trial of 319 patients with prior brain bleeds and AFib.
What happened there?
They were randomized to either take a DOAC or withhold anticoagulation entirely. Now, the DOAC did its job brilliantly on the clot front.
Okay, good.
It dropped subsequent ischemic strokes down to 0.8 per 100 patient years, compared to 8.6 in the group withholding the drugs.
That's an enormous reduction in strokes, but
Yeah.
I sense a however coming.
However, that benefit was partially offset by an increase in recurrent brain bleeds.
Ah, there it is.
Yeah. The DOAC group saw 5 recurrent bleeds per 100 patient years, compared to just 0.8 in the avoidance group. So yes, DOACs are vastly safer than warfarin, but they're absolutely not risk-free.
The scale is always balancing.
Hmm.
The 4 to 8 week rule, the DOACs, the CHADS-VASc scores, they all work nicely for your standard AFib patient.
Right.
But real life in an emergency room is rarely standard. What happens when the patient doesn't fit the neat 4 to 8 week window? Like, what if they have a mechanical heart valve?
Oh man, that takes us to the extreme edges of this matrix. Mechanical heart valves are essentially relentless clot-making machines. Yeah, because the body recognizes the valve leaflets as foreign material, and the sheer stress of the blood rushing over the metal or carbon constantly triggers the coagulation cascade.
Oh, that makes sense.
The risk of a major embolism is 4 times higher if these patients are taken off warfarin.
Yeah.
And if that mechanical valve is in the mitral position where blood flow is slightly slower than the aortic position, the thromboembolic risk is almost twice as high.
So telling a mechanical mitral valve patient to wait 8 weeks for their brain to heal is essentially a death sentence from a stroke.
Precisely. Because of this extreme risk, anticoagulation must be resumed on a terrifyingly fast track, typically 1 to 2 weeks post-hemorrhage.
1 to 2 weeks. The brain has barely had time to absorb the blood, the scar tissue hasn't fully formed, and we are turning the heavy-duty blood thinners back on.
We have to. Some observational data, including a meta-analysis of 435 patients, suggests the mathematical sweet spot to minimize both clot and bleed risks is somewhere between 10 to 15 days.
Okay.
There's even data suggesting anticoagulation may be considered as early as day 6 in highly select patients.
Day 6. Wow.
Yeah, though holding for at least 7 days is generally seen as the absolute baseline to avoid immediate catastrophic rebleeding.
That is white-knuckle medicine.
Mhm.
Now, let's flip to the other extreme. We talked about the clot-making machine. What about the extremely fragile brain vessels? Earlier, we established that deep bleeds are different from lobar hemorrhages. The ones near the surface of the brain.
Yeah.
Why are the surface vessels so dangerous?
Because of a condition called cerebral amyloid angiopathy, or CAA.
CA, yeah.
Right. This is a pathology where rogue amyloid proteins systematically deposit themselves into the walls of the small arteries on the surface of the brain.
That sounds bad.
It is. It degrades the vascular muscle, making the blood vessels incredibly brittle. They become like wet tissue paper. CAA is actually the primary driver of lobar hemorrhages.
So how does CAA change the math on our glowing scale?
It completely shatters the scale.
Really?
Yeah, because the vessel walls are physically degraded by amyloid protein, the recurrence risk for a bleed is extraordinarily high, regardless of what you do. We're talking up to a 15 to 20% annual recurrence rate.
20% a year?
Yes, especially if an MRI shows existing microbleeds. Because of this, doctors typically enact a heart stop.
A hard stop, meaning no blood thinners.
Right. They do not resume anticoagulation for most patients with lobar ICH attributed to CAA unless there is a wildly compelling reason, like that mechanical heart valve we just talked about.
But surely they've tried, right? Have they tested the safer DOACs on CAA patients?
They tried. There was a major trial evaluating DOACs in patients with prior ICH, which included a large cohort of lobar bleeds. The trial was designed to run for years, but it had to be abruptly stopped after just 699 patients.
Why did they pull the plug?
Because the recurrence rate of brain bleeds in the patients with lobar ICH was just too dangerously high.
Oh, wow.
The safety monitoring board had to step in. It was simply unsafe to continue giving them the anticoagulants, even the highly targeted ones.
That is a brutal reality. But it leaves a massive problem for you, the listener, to consider. If you have a patient with AFib who is actively forming clots in their heart, but they have CAA and absolutely cannot take a single drop of blood thinner, what on earth do you do for them? Are they just sitting ducks waiting for a massive stroke?
Not entirely. This dilemma forced medicine to look for non-pharmacological solutions.
Okay.
If we can't use chemistry, we have to use mechanics. Specifically, a procedure called left atrial appendage occlusion, or LAAO.
Left atrial appendage occlusion. What exactly are we occluding?
Well, the vast majority of the dangerous blood clots in AFib patients form in one highly specific anatomical location. It's a small, windsock-like pouch in the top left chamber of the heart called the left atrial appendage.
A pouch.
Yeah, and because the heart is quivering in AFib, blood stagnates in this little pouch and congeals.
Gross.
Very. With LAAO, a cardiologist threads a catheter up into the heart and deploys a small, umbrella-like device to physically plug and seal off that pouch entirely.
That is brilliant. If you literally board up the room where the clots are manufactured, the blood can't pool there and the clots can't form.
Exactly. It's a purely mechanical alternative to long-term anticoagulation, and the data shows lower hemorrhagic stroke and bleeding rates compared to keeping these incredibly fragile patients on warfarin.
So to synthesize this incredible journey we've been on, managing post-hemorrhage antithrombotic therapy isn't just, handing out a pill. It is a highly individualized, high-stakes matrix.
Yeah.
You're constantly balancing timing. Is it 3 days for aspirin post-surgery, 4 to 8 weeks for standard AFib, or a terrifying 1 to 2 weeks for a mechanical valve?
Yeah.
You are analyzing the anatomy of the bleed, a deep hypertensive rupture versus a surface-level lobar bleed caused by amyloid proteins.
Right.
And you are rigorously applying precise math, pitting the CHAS-VASc clot risk against the has-bled bleeding risk.
And, the physician is doing all of this while sitting across from a patient who is understandably traumatized.
Yeah, of course.
They're trying to explain why the very concept of blood thinners, which just caused a catastrophic brain event, is exactly what they need to survive their heart condition. It requires mastering the biology, the statistics, and the humanity of medicine.
Here's where it gets really interesting, and this is the final thought I want you, the listener, to mull over as we wrap up today's deep dive.
Yeah.
We've spent this entire time obsessing over the calendar, right?
Right. Day 3, week 4.
Exactly. Day 3, week 4, week 8. Figuring out exactly when to restart the risky drugs we currently have. But what if the future of neurology isn't about perfectly timing a dangerous drug at all? What if we are on the precipice of developing smart antithrombotics?
Now, that would be something.
Imagine a molecular therapy that can exclusively target pathological, disease-causing clots in the heart while remaining completely inert in the brain, allowing it to naturally heal a hemorrhage without any interference.
That would fundamentally rewrite the rules of medicine. The agonizing tension of the glowing scale we spent this whole time discussing would just vanish.
Exactly. The real breakthrough might not be a better calendar or a better scoring system, but a fundamentally different kind of medicine altogether. Until that day comes, doctors will keep balancing those glowing scales, trying to fix the burst pipe while keeping the power grid running. Thank you for joining us on this deep dive. Keep questioning the consensus, keep digging into the data, and we will see you next time.